Hi, and welcome to Staying Healthy. How are you doing, Dr. Stevenson?
Fine, thank you.
Thank you. Great. This is Dr. James Stevenson. He's the neurologist at Waldo County General Hospital, and today we're going to be talking about headaches, a very common problem for many people. We'll be discussing migraines, how they differ from other headaches, how they're treated, how they're diagnosed, and hopefully get some really good information out to our community members about headaches. So the first question, I think the most obvious one, is what is a migraine and how is it different from another headache?
Well, migraines, everybody thinks about as severe headaches, and often they can be, but sometimes they're less severe. Migraines are defined from a medical standpoint as headaches that meet certain criteria. There's no test that says this is a migraine or this is a sinus headache or this is a tension headache. So we look at clinical criteria, and to make a diagnosis of migraine, somebody has to have episodic headaches that come and go, and I think there have to be 5 or more over a period of time.
All right.
But the headaches are characterized by certain qualities. A headache that is one-sided, that is throbbing, that is moderate to severe in intensity, or is worsened by activity is sort of the list A.
Okay.
And 2 of those features start to qualify you for calling this headache a migraine headache. From a second list, if there is nausea or vomiting associated with the headache, or if there is sensitivity to light and sound, we have a diagnosis of headache. So 2 items from column A and 1 item from column B with recurrent headaches is what is required to define migraine.
Okay. And do you treat a migraine different than you would treat a regular headache?
Yeah, there are a variety of specific medicines for migraine. I think there are now more than half a dozen specific treatments for acute migraine. So when people just have migraines from time to time, they can take these medicines and hopefully get rid of the headache. Different medicines work better or less well for different individuals. So it's nice that we have a variety of medicines to choose from, because sometimes one person will respond to medicine A and the next person will respond to medicine B. For those people who have very frequent migraines or for whom the acute treatments don't work well, we also have a number of medicines that work as preventives. They reduce the frequency of the migraine and hopefully severity of the migraine. And these, there are a whole handful of those, mostly drawn from other medicine, other disease state medicines. So we sometimes will use blood pressure medicines, sometimes anti-seizure medicines, sometimes antidepressant medicines. So a whole host of different preventive strategies for people whose migraines are more severe or more frequent or more disabling.
All right, and you are a neurologist. Does someone need to see a neurologist, or is this something that their family practice provider can help them with?
Family practice providers can help many people with migraines, as long as they recognize the headache as a migraine, and that's very important. There have been two studies, the first done in 1990 and the second done in 2000. And it turns out that half of people whose headaches meet criteria for migraine have not been diagnosed.
Oh.
And in 1990, it didn't matter a whole lot because we didn't have very good treatments for the migraine. But in the year 2000, when we've got good treatments for these headaches, it's important that they be recognized. And often people don't go to their primary care physician, or their headache is the last thing they mention as they're heading out the door after listing a whole host of other medical issues with their primary care physician. But certainly anybody who has troubling headaches, especially a headache that is accompanied by nausea, should ask their primary care physician about, could this be migraine, and try for some treatment.
Wonderful. What we'll do is we'll put your list up so people can see that. Is it a pretty good idea for them to print off the list and go to their doctor and say, I have this and this is how frequent it is? We tell people a lot of times to write their questions down ahead of time. So probably it would be helpful for them to take that list with them when they go?
You know, I think that basically if they go to their primary care doctor and say, I think I have migraine, that opens this diagnostic possibility to their primary care doctor, who probably knows how to treat them, as long as the treatment works well and effectively. Because, you know, it's interesting, people who go to their doctor seeking treatment for headache almost always have migraine. It's very uncommon for people to have tension-type headaches that are troublesome enough that they'll seek medical attention. And similarly, people who have sinus headaches, and I have to make an aside here.
All right.
Sinus headache is almost a non-existent entity.
Oh, I always think I have a sinus headache.
Yeah, well, you probably don't. I mean, and we diagnose ourselves with migraine. My mother died with sinus headache. My mother diagnosed me with sinus headaches when I was a little kid. These headaches throbbed. I looked to get into a dark place. And all my life, until I went to neurology school, I thought I had sinus headaches. But after learning about how we define headaches, I recognized that my headaches are migraine. Fortunately, they're very, very mild, but I know now that I can take effective treatments and get rid of these rather than suffer with a nagging headache for 3 or 4 days on end.
Now, you keep talking about effective treatment. What about Tylenol, ibuprofen? I remember hearing something once about rebound headaches. Should people, you know, if it's, I mean, are those appropriate treatments, or when do they no longer become appropriate?
The over-the-counter medicines and some prescription medicines are effective treatments as long as they work, as long as they get rid of the headache. People who take over-the-counter medicines who don't completely get rid of the headache, they'll say, oh, it takes the edge off the headache. So they take more, and they take more, and they take more. And there is this entity called an analgesic rebound headache. Basically, when the medicine that you've taken this morning wears off, the headache comes back, so you take another dose. It works for a while, the headache comes back later. This is rebound headache, and it's estimated that people who take analgesics, over-the-counter medicines, more than 15 days per month are susceptible to these rebound headaches. And those can go for weeks, months, years, and become very, very difficult to treat. So it's very important that you take medicines for headaches that work to get rid of the headache, that knock the headache out, that don't just knock it down a little bit so it comes back later.
Excellent. Thank you very much, Dr. Stevenson. This has been very, very helpful, and I know that I probably will be talking to my doctor because I meet much of that criteria, and I think a lot of people probably do. So thank you very much, and have a great day.
Thank you. You're very welcome.